It's my pleasure now to introduce Dr. Bindu Menon, who is our next speaker for tonight. And Dr. Bindu Menon is the head of the department and senior neurologist at the Apollo Hospitals. She, as you can see, has been a teacher for more than 19 years. She has over 70 publications in various journals and has a large number of presentations in various scientific fora. And she's been conferred a fellowship from the Royal College of Physicians in Edinburgh, the Indian Academy of Neurology, the Geriatric Society of India, the Indian College of Physicians, and the World Stroke Organization. And she has numerous uh, first time credits to her life. She has founded the Bindu Menon Foundation in 2013. She started several novel projects: Neurology on Wheels, which is an outreach program, mobile application app for epilepsy help, tele awareness program, and a stroke help app. So you can see she is multi talented, and she's a kind of wonder woman for epilepsy in India. And it's wonderful to have Bindu here today. Today, she's going to speak to us on nocturnal parasomnias mimicking seizures in this setting. She has about 20 minutes, and I'll hand over to Bindu. All yours, Bindu.
Thank you so much, Dr. Joy, for making me a part of this lecture schedule. And thank you so much, Dr. Harden, for that excellent overview and taking us through the latest intricacies of the sleep architecture and new novel insights. And Neeraj, of course, for making the transition between the epilepsy and the parasomnias probably a little bit better for me, so that I could probably skip on such slides and people could go on to the sleep-wake transition easily. Abnormal movements and behaviors during sleep are part of a larger group of nocturnal events, and that may occur during the sleep cycle, or it can occur during the sleep transition in and out. And most of these are very common in the early stage of life and predominantly occurring in 15 to 20% of the children, and in adults around less than 4% of them. And Rohit, I'm not able to move my slide.
Ma'am, can you try clicking on anywhere on the slide area, and try to change it?
Now, is it moving?
No, ma'am, no.
Yeah,
You can stop it and share it once again, yes.
Yeah. Sorry for that. Stop screen, and I share again. Yeah, now that's fine. I'm a slide
Yes.
now. Yeah. So
Thank you.
we have already been taken through the stages of cycle. So there is an orchestrated, stereotypical, I should say, where the one goes through the various stages of sleep in the whole pattern, with stage one of a slight sleep and transition from awake to sleep, and stage two with going into which is more often leading to the seizure patterns, which we have heard from the previous speakers, and stage three being the deep sleep. So one stage is as light sleep, and stage three as deep sleep. And as we have already heard, that epileptiform discharges are likely to propagate during the non-REM sleep, along with the traditional drowsy, e.g. arousal periods. And because there is a synchronized state between the reticular activating system, the thalamocortical neurons, and the pyramidal neurons of the cortex. And that synchronized state leads to more epileptiform discharges. And the non-REM sleep, it activates the focal epileptiform abnormalities as well in patients with focal epilepsy. More spikes are seen during this deeper stages of slow wave sleep compared to the later stages of sleep. And nevertheless, to say that the light sleep, that is the stage 2 sleep, is where we get more seizure activity, that is, more seizure events are recorded, but more interictal discharges are more seen in the deeper stages, that is the stage 3 sleep, that is the end stage of sleep. Also, that stage 3, that is the deep sleep, is the stage where parasomnias are very frequently noticed, and that too in the first half of the cycle. The REM sleep, we would say that it is more of a protector because it's a desynchronization, it's an asynchronized cellular discharge patterns. So the epilepsy is less commonly seen in this, but that's the stage where we dream. And that's the stage where there is a muscle atonia because the descending corticospinal tracts are inhibited and the person is in a stage of atonia, but except for his eye movements and except for the various dreams which and the person has during that period. So one looks at the nocturnal events. One which we are going to look at are the parasomnias, which could be the REM, the non-REM, and the other parasomnias. But then if one looks at the clinician should understand that there are several nocturnal events which could range from a normal nocturnal events, which are benign sleep myoclonus of infancy and the hypnic jerks in the transition period one can have, with the greater awareness which is happening among the individuals and among the public. Even the hypnic jerks, people are taking it on a cell phone and video recording it and getting to the clinic and asking whether this could be a seizure, whether this could lead on to a seizure. And or we are talking about the abnormal nocturnal movements, the movements which are way different from the seizures or the parasomnias, that is a restless leg syndrome, the periodic leg movements of sleep, the sleep-related leg cramps, the bruxism, and the rhythmic movement disorders are the whole load of the nocturnal seizures which have been elucidated clearly, that is the epileptic encephalopathies, the arousal or the sleep deprivation, JMEs, the childhood epilepsies, the Rolandic as well as the occipital spikes, the Landau-Kleffner syndrome, which have got EEG discharges predominantly during sleep, which leads to the language disturbance, and the sleep-related hypermotor epilepsy, or the in some cases the sleep-related temporal lobe seizures as isolated seizures and initial presentation. So what are parasomnias? They encompass all behavioral or experiences which are associated with the sleep, which are undesirable or unpleasant to the sleeper and also people who are nearby. They are associated with a normal sleep process. They arise predominantly out of sleep and are associated with specific sleep stages. So the classification of parasomnias according to the International Classification of Sleep Disorder 3 could be as NREM related parasomnias, the REM related parasomnias, the other parasomnias are the isolated symptom or the normal variant. The NREM, the important ones are the disorders of the arousal, which could be the confusional arousal, the sleepwalking, the sleep terror, and the sleep-related eating disorder. The REM are the sleep behavior disorder, isolated sleep paralysis, nightmare disorders. The other parasomnias, which could happen in any of the cycles of the sleep stages, which is the exploding head syndrome, the sleep-related hallucinations, sleep enuresis, parasomnias due to the medical disorders, or the medications, or the unspecified ones, and the isolated symptom, which is the sleep talking. There are a whole lot of parasomnias, but then the ones we are interested for this talk today are the ones which are which get confused with nocturnal seizure or a nocturnal epilepsy, and we are going to touch upon the disorders of arousal, the three, and the REM sleep behavior disorder. So I'm going to go to the clinical aspects of the NREM parasomnias, which are very, very important because that's how one tends to diagnose the patients who come with abnormal events, abnormal behaviors. So if one looks at the non-REM parasomnias, the common features on the right side of the slide, which are shown here, are same for all of them. They have vocalizations during the event. They have complete amnesia of the event. They cannot remember what had happened. They cannot be alerted out of that. They have a decreased responsiveness of awakening. So if they're having the event and a person tries to go and tries to wake them up out of it, it's difficult. The termination is usually a progressive one. There's no abrupt onset and an abrupt offset of it, and there is a slow progression, and then the person returns to sleep. There's usually a post-event confusion, and most of them are noted to have a family history of parasomnias. So if we look at individual ones, the confusional arousals, the sleepwalking, and the sleep terror, the confusional arousals, all of them are predominant in the N3, that is the deep sleep. A confusional arousal can also occur in stage 2 sleep also. They can occur at any period of time when the sleep is interrupted. If the sleep is interrupted from an external stimulus or an internal stimulus, external, if somebody comes, puts on the light, tries to put a jerk, or an internal stimulus, which is jerk, if the person has cough or sneezes, or any of those events can sort of trigger off a confusional arousal. They last seconds to minutes. They can also, it is very important to know that this can accompany where the various other sleep disruptive conditions like the obstructive sleep apnea. That's why it is very important to note and treat the obstructive sleep apnea, OSAs, and in a way the confusional arousals can be minimized to a large extent. In patients with confusional arousal, they rarely get out of the bed. They are on the bed, they get up, they look confused, they look around, they may vocalize, they may talk. So the injury risk to these patients are a little lower, and they have a normal autonomic system at that point of time. The sleepwalking could be addressed as the person has got an incomplete arousal and with mobilization. So one could look at it in that way. It's usually in the first third of sleep. It again lasts from seconds to minutes. It is seen in the deep sleep stage, and it could matter in a spectrum of behaviors. It could be a complex behavior in which the patient could be just alerted from the consciousness, and the patient would get up, get out of the bed, walk, open the door, open the gate. And if it's a door, it's a bigger window, the patient can open the window and can probably walk out of the window and can injure himself in a very bad manner. However, the most important part is the patient's, in these cases, the patient's eyes are open, unlike in an RBD disorder where the patient's eyes are closed. In this, the patient's getting out of the bed is usual, obviously, because he is sleepwalking. There's normal autonomic activity at that time, and the injury risk is high, particularly if in certain circumstances. Otherwise, the patient may walk around, move around, go open, get into another room, and probably sleep off. But if the patient is disturbed and when the patient is tried to halt his activity, then the injury risk increases. Then the last one is the sleep terror, which we are describing here, is again in the deep sleep. It's again in the first third of the sleep, lasting for around 10 minutes. They commence with the sleeper sitting up in bed, emitting a loud scream, and showing the typical autonomic manifestations of intense fear. These patients sometimes get out of bed, but more or less they are sitting on the bed and vocalizing. In fact, vocalizing to an extent which is very scary for the caregiver, for the parents, and for the bystander there. There is an increase of an autonomic activity, and the injury risk is again very high if the person is tried to stop his activity. In this confusional arousals, it is also very important to find out if the patient is on any medications or the patient has any sleep deprivation, because one can imagine that if the person has got a sleep deprivation, the body tries to decrease the sleep depth by increasing the deep sleep so that the quality of the sleep is more. And if the deep sleep is more, the patient has got an N3 which is going, patient gets into the N3 very fast. The patient starts to get confusional arousals very fast. So especially sometimes in elderly, though these phenomena are very common in children and in the young adults, if it is in elderlies, the confusional arousals, one should always have a quick look at his medications. So this is a diagrammatic representation in a graphical form in which one could see that if we look at the behavioral pattern of the patients with parasomnias, it could include the arousal, the non-agitated motor, or the distressed emotional. The x-axis holds the time limit from 0 to 10 minutes, and the y-axis on three demarcated forms of arousal: non-agitated, motor, and distress. And one can clearly see that the confusional arousal, it's restricted more or less to the arousal, though the time of the arousal pattern and the parasomnia can extend till 0 to 10 minutes. The sleep terrors are the ones which has got an autonomic activity which is very high on the cards, and which have got a distressed and emotional feel to the whole parasomnia. The somnambulism does not have a emotional or autonomic activity to it to any extent, except in anecdotal cases. But then they have a non-agitated motor, and they can go on to this. The black one is the usual arousal, so the usual sleep terror, the somnambulism, or the dotted forms are the ones which can extend to 10 minutes as well. So the REM parasomnias, the common features again, they are very rapid. They awake the patient, but the person can be awakened easily. They do not have amnesia of the event, unlike a non-REM parasomnias. There's a usual recall is usually present, and the person can bring out his dreams, and he enacts his dreams as well, and can remember his dreams with extreme vivid details. And there is no post-event confusion. So the three parasomnias which are very common are the REM sleep behavior disorder, the sleep paralysis, and the nightmare. The REM sleep behavior disorder is any time, but most frequently in the last third of the sleep. There is a marked vocalization. They may enact their dreams. They may start playing. They may start acting like movie star. They can have a spectrum of events which could be different in each RBD related parasomnia for that particular individual. He does get out of the bed. The injury risk may injure the self or partner as part of dream enactment, and we know that in an elderly patients, this could be a harbinger for more neurodegenerative diseases, especially Parkinson's disease or Alzheimer's disease. And the proper counseling to the partner needs to be given, because the injury to the partner can be very severe. They have a normal autonomic, the family history, if it is not part of a neurodegenerative, they could be have occasional family history could be present. Sleep paralysis could be any time. Vocalization is slight. There could be moaning or groaning. The getting out of the bed is rare, because it's obviously the name suggests that it's a sleep paralysis. There is no risk of injury in these patients. The normal autonomic and their family history is very commonly seen. The nightmare disorder, again, which could be very easily confused with the seizure event, is any time, but most frequently in the last third. They vocalize, they don't get out of the bed. The injury risk could be there. The autonomic activity is very high. They can talk, they can scream, and there is a family history which is very frequently seen in these patients. And the differentiation from the non-REM and the REM is they are mostly more frequently in the last third of the sleep, not the ones which are very frequently seen in the non-REM, which are very frequently in the earlier 1/3 of the sleep. So the diagnosis has to go through the clinical, the polysomnography, the overnight video EEG. Neeraj has already told us now in this technology friendly, it is not very challenging for us to tell the bystander to have a video recording at home, even though there are nocturnal events, so that we can know what is happening. And then the self-reported questionnaire and the FLEP and the structured interview for the nocturnal frontal lobe epilepsy could be a way of knowing from the clinical diagnosis, which goes through how the patient was, whether he was amnestic of the event, whether there was a postictal confusion, and you keep marking. And if you have a number which is less, then it goes in favor of parasomnias. Patients might require an EEG or the long-term video monitoring. The autonomic activation could be very helpful for us to know, especially in cases of sleep terrors or REM nightmares, where they're very classical along with the vocalization and screaming part. The EEG part has video polysomnography. There are important tools. They do not have 100% specificity or sensitivity, but they are extremely important tools for every kind of motor manifestation during sleep. They provide a recording of the motor events, and we know that whether the behaviors during the sleep and the correlation with the EEG. The polygrammatic parameters, the respiration, and the other parameters would be very helpful for us to know whether they are night terrors or nightmares. The epilepsies associated with sleep, as has already been mentioned, how do we differentiate an epilepsy or a parasomnia, which is an REM or a non-REM sleep? So as we see here, the slow wave sleep, this is the stage where most of the parasomnias occur, but then they can always flow from stage 2 to the slow wave sleep, as we have already seen. And most of the epilepsies which are associated with sleep are usually because there is a state of relative synchronization. There is a state of arousal, as in GME, where there is a hypersynchronization, or the cholinergic pathways in the ascending arousal system, the circadian mechanisms which are having a part in activating the interictal epileptiform abnormalities. Having said that, it is not unusual to find that patients could have an overlay of both of the symptoms in a particular group of patients, and that could be a characteristic, and that could be a true diagnostic dilemma because parasomnias and nocturnal seizures. The most important of it, which has been elucidated by Neeraj, is the nocturnal frontal lobe, which is now known as a sleep-related hypermotor epilepsy. They end suddenly, they begin suddenly. There is little, if any, post-ictal confusion, and the patient immediately gets back to sleep. So they could be from brief motor attacks, which could be confused for the disorders of arousal, or they could be the hypermotor epilepsy, which could be again confused for a somnambulic episode if the patient starts walking off, or there could be prolonged complex ambulatory behavior. So all of these can be divided into the hyperkinetic with the bimanual and the bipedal automatism, which are ballistic. They're violent movements with explosive vocalization like screaming, shouting, obscenities, or travelings or laughing. The awareness is frequently preserved in these patients, unlike in the patients which we saw in non-REM somnambulation or the sleep terrors, where this patient is not aware of the episode and the patient is able to control the motor behavior. So the localization is usually in the mesial, dorsolateral, orbitopolar, opercular, and larger lobar cortical. The other ones, which is a very stereotypic and which can be usually got from the history or from the phone recordings when the patient is in classical asymmetric tonic dystonic, which is localized to the SMA or the posterior mesial frontal cortex. The more common is when the patient may jump out of the bed and run around in a repetitive manner, which is also known as epileptic nocturnal wanderings, and which could be very difficult for sleep-wake and difficult to differentiate from the somnambulism or the sleepwalking, and for the experts in sleep medicine. And this suggests that it's not only the frontal lobe which is involved, and that's why the name, the sleep-related hypermotor, where the circuit has changed into the anterior cingulate, orbitopolar, and the temporal regions. So if we take it in this tabular form, the most predominantly one should consider the age where it happens, which is very common. The non-REM parasomnias are very common in the childhood and adolescent. The REM is very common in the older. The nocturnal seizures are variable. The psychogenic events, one should not forget, as has been seen in the previous case, that the abnormal and bizarre movements might be judged to be a psychogenic event and might be referred to a psychiatrist for better treatment. The time of occurrence, one can have the number of attacks the patient has, and to see whether the type of attacks are stereotypical or they are in polymorphic in nature. The memory of the event is usually can be preserved in a patient with a nocturnal seizure. The REM patients, REM RBD, the dreams can be recalled and they can have a vivid recall of the event as well. The polysomnographic could find there is an arousal from the delta sleep in patients with non-REM parasomnias. The EMG tone is very important. We understand that there is a sleep atonia during that event. The EMG tone will help us during a polysomnography and actigraphy recording. The nocturnal seizures obviously may lead to find an epileptic spike, but then if the hypermotor spikes with a lot of bizarre movements, sometimes it might be difficult. And the psychogenic events, they occur from the awake state, the patient's eyes are closed, and the events, the EEG is classical and typical of an awake, but the patient is seen and assumed that the patient is sleeping. More commonly, the frontal lobe seizures and the non-REM parasomnias, the diagnostic evaluation, a day lab video EEG recording with only an awake is usually and essentially always normal, but a day lab video EEG recording after sleep deprivation can increase the abnormal events to 50%, while a 24-hour video EEG recording with a daytime and nocturnal event can increase the more than 75%. The age of onset, the family history, the attacks per month, the attacks per night. The attacks per night are also very important because the non-REM parasomnias they have an attacks frequency of probably 1 attack per month per night. But in a frontal lobe seizures, one can have a stereotypic attack of the patient recorded around 3 or more. So there many attacks in a month in a particular sleep can go in more in favor of a frontal lobe seizure. They are smaller in duration. There is a typical onset and an offset, and the trigger factors, usually there are none. However, in non-REM parasomnias, one can see from the history itself there could be a sleep deprivation, there could be a febrile illness, and alcohol intake or stress. And associated conditions may or not be present, but if there is present, it could go more in favor. But frontal lobe seizures also can have OSAs, as has been seen in the previous case, that treatment of the particular syndrome OSA can lead to remission, partial remission of the frontal lobe seizures. An excellent flow chart for a scheme for differentiating RM and non-REM parasomnias from frontal lobe epilepsy. First, it starts with, we can see that everything is very clinical, and one goes to this format of the chart that does the patient clinically arouse, that is to normal wakefulness at the end of the episode. If he does, then is there a discrete offset to the event as opposed to the grad? If there's a discrete offset that he comes off immediately, then it could be a nocturnal frontal lobe epilepsy that is a seizures of a hypermotor epilepsy. Or if the patient remains prone and does not get up and there's no offset and is a gradual transition and he's coming off from out of the sleep, then it could be a parasomnias. The event during that is a semiology of the event during the event when the patient had, whether there is a versive head turning, dystonic posturing, yes, then there is a nocturnal frontal lobe. If there is no, then there is a parasomnia. The disorders of arousal, a new technique one could always, whether the subject, the patient, polysomnography and prolonged long-term EEG recordings would definitely not be available in all centers, would not be available for all patients. So one should be careful when they are being subjected and referred to a higher center. If they have a typical feature, there's onset during childhood, less than 1 episode per month, episodes in the first third of the night, long episode duration lasting for 7 to 10 minutes. They're non-stereotype. Every pattern seems to be different from the other. There is a partial to incomplete amnesia of the event. Then probably these patients with so many typical features may not need to be subjected to a video polysomnography, and a clinical diagnosis should be enough for these patients. But if there are certain atypical features like an adult onset, there is short episode duration, there are very stereotypical patterns, cycling, bipedaling, high frequency of episodes, 3 to 4 in the night, episodes in any part of the night, and the patient has no amnesia of the episode, there is recall of the event, then the patients could undergo a video polysomnography. If the episodes are recorded, then there is a diagnosis, but patient might be needed to subject to long-term video EEG recording or polysomnography as well. So are we looking at a spectrum of disease in which we saw there are several differences between the non-REM and the sleep-related epilepsies, but then definitely there are a lot of commonalities between them. And is this there? We are looking at a continuing between the two conditions where there is a genetic predisposition, there are triggers. We know that sleep deprivation has a trigger. There are certain medications, as Dr. Harden has pointed out. The concomitant sleep disorders, OSAs, could be seen in both of them, and leads to a sleep dysregulation with a non-REM and an REM imbalance. and confusional and arousals increasing with a slow wave sleep enhancement, where there is a central pattern generator which increases the epileptiform network involvement and probably going into that stage of epileptic episodes or turning over and giving off to a parasomnia episodes. And probably more should be there with all the insights into the sleep coming forth from the first lecture. We know that we will get to learn more and more about this. So sleep epilepsy and parasomnias are complex interplay. History is extremely important most of the times. Clinical semiology, the duration of the episode, the recall of the event, the timing when that happened, and the age of the patient, and the other diseases which the patient could be having could help us in making a clinical diagnosis in most of the patients. Epilepsy per se would require EEG, a prolonged EEG, and nocturnal and a sleep EEG, a sleep deprived EEG as well. The pharmacological management is vital in some select cases. Good counseling to the parents should be enough in a majority of them, but need to overweigh the risk of the medication against the potential hazard of an untreated parasomnia, as we saw that the risk of injury is high in many of them. Thank you so much.